Good morning. I guess I'm the only nephrologist here. Everybody's an endocrinologist. Okay. It's an honor and a pleasure for me to present Dr. Ahmed Hassoun, who's a prominent endocrinologist and an excellent talk today will be about hypertension. He is a graduate of Mayo Clinic, I believe in 1996. And currently he holds the position of the chairman of the research and medical education in Dubai Diabetic Center. He is an active member in national and international research. So let's welcome Dr. Ahmed. He'll be talking about the goal in hypertension goal in diabetic patients. Okay.
Thank you, Mr. Chairman. Thank you, gentlemen, ladies and gentlemen. Good morning, still morning, and you're still active. This is my second presentation, and it's going to be talking about managing diabetes, hypertension in diabetes, people with diabetes, with some discussion about the important goals to be used in such, individuals. This is my disclosure slide. I will start with a background and introduction, followed by two cases. This is a meet the professor or meet the expert, I think, so I'd like to be maybe interactive if possible, and discussing the guidelines updated and giving you some messages to take home with you. As we discussed yesterday, if you were here about the global epidemic of obesity and hypertension and diabetes, we have the same problem here with hypertension. You can see, according to this updated hypertension, World Heart Federation roadmap, updated in 2021, we have a high prevalence, about 1.4 billion adults with hypertension. And apparently, the prevalence is increasing in low and middle income countries. Consequences, as you can expect, would be much more people with death and responsible for 50% or more on heart disease, stroke, and heart failure cases. And if we can do something good about treating this problem, we would have saving a lot of money globally. You can estimate it here that about $100 billion per year can be saved if we do good management and controlling or preventing even the problems. And you can see in the small map here, your country is there. It's one of the high prevalence, Bahrain, you can see it there, even the wording there down, second one after American samosa. And it is a leading cause of death and disability in all over the places, and you can see in the world it's estimated 13.5%, and in our region, the Middle East and North Africa, it's even higher than that, 16.5%, with a disability about 6.1%, all this due to hypertension. Now, as you probably know, that there are different thresholds used for defining hypertension, and every one of us probably uses different ones, but I think we'll try to get at the end of this is what is the best to use. And if you can see, this is from the US. If you use the American College of Cardiology threshold of 130/80 as the cut point, the prevalence was 46%, while if you use the lower, so the higher threshold means 140/90, you will have a lower prevalence. So we can increase the prevalence and reduce it according to what threshold we are following. But more importantly here, you can see that in elderly people above 60, it is estimated to be more than 60% people having hypertension. And this is the prevalence in the Gulf from some recent prevalence articles. Looking at Bahrain here, I highlighted Bahrain, and the country I came from is UAE. You can see that UAE probably the lowest in the prevalence, and Bahrain is in the middle. Surprisingly, unlike obesity, Oman is the highest in the prevalence, unlike they were the lowest in obesity, as we saw yesterday. It's a devastating disease. It can lead to a lot of vascular problems listed here: the heart, infarction, death, heart failure, brain with hemorrhagic stroke and ischemic stroke, peripheral vascular disease in the arteria in the periphery, and end-stage renal disease, and not to forget, also not mentioned here, is retinopathy, especially in our people with diabetes. The problem is we don't have much of awareness, and the treatment are not satisfactory, and the control of hypertension is not really that good. And you can see here in this study called the PURE, looking into the Middle Eastern and Africa, you can see that in 4 Middle East countries here listed, United Arab Emirates, Iran, occupational Palestine territory, and Saudi Arabia, and you can see the awareness in that was 49% about hypertension. The treatment was only offered in 47%, and the control is only 19%. And that we're talking about 140/90 level of blood pressure. I think it seems from this recent slides here that from studies recently done, looks at the control is getting better. You can see Bahrain is better than what we saw, 19%, and even UAE is better, 25%, as you can see in the other Gulf countries. But still in Egypt, apparently not that good, according to these statistics. It's important to remember that systolic blood pressure is a better predictor in elderly above 50, because the diastolic blood pressure is not going to be of help above the age of 50, because people will lose the elasticity of their vascular. So you will see a decline in the diastolic blood pressure, especially above the age of 50. Now, a few points to remember about the diabetes and hypertension. As you can expect, especially in type 2, they are comorbid together. The prevalence, again, depends on the age, the BMI, and ethnicity. It's a major risk factor for atherosclerotic vascular disease and microvascular for our patient with diabetes. And it's important to differentiate that in type 1 diabetes, often hypertension results from a kidney complication happening in these patients. Unlike in type 2, they are coexist hypertension and diabetes from the beginning, or even sometimes you have hypertension even before diabetes. It's even worse when you have hypertension with diabetes. You can see here, this is the old study of Mr. Fitt, looking at different levels of systolic blood pressure. And you can see clearly that people with diabetes have increased cardiovascular death rate approximately twofold in all different category and levels of blood pressure. So let me take you to two cases actually, to see what you think about how you manage it. Some people will find it easy, some people will have some question about it. The first case is a 48-year-old lady with a strong family history of type 2 diabetes and hypertension, presented for general checkup after being told that her blood pressure was elevated, 144/90, medications at that time, vitamin D and omega-3 Omacur. She is walking 20 to 30 minutes almost daily, watching her diet as advised. On physical examination, she is obese. Blood pressure is still on the higher level, 143/87. Otherwise unremarkable, and the laboratory findings here, CBC, chemistry, renal profile, lipids were all unremarkable. Hemoglobin A1C was 6.3 and fasting plasma glucose was 118. I'm sorry, I'm using the milligram. I'm not sure if you're using the same or using the millimoles. So the question is for our people here and the audience and who is listening to us is, if you have such patient, what would you do? Would you start about hypertension focusing? Would you start a small dose of hydrochlorothiazide, starting amlodipine 5 milligram, starting atenolol 50 milligram, starting lisinopril 5 milligram daily? Let me see if we can work it interactively. What would you do? Anyone will choose A? Some. How about B, amlodipine? Another one. Starting atenolol. C? Not many. Starting lisinopril, 5 milligram. A few more. Okay, good. Well, I think the majority won here because the answer is lisinopril, 5 milligram. And just to give you some brief things, let me go back to the case here if I can. One thing in the case, if you did not see it, that hemoglobin A1C was 6.3% and fasting plasma glucose was 118, so the patient had pre-diabetes. And it's important, a lesson from this case is that when you're trying to treat somebody with hypertension with that, you need to look into, can we do something to prevent, diabetes from developing, and that would be an ACE or an ARB to be used. And this is a slide reviewing some studies, randomized trials, analyzing the incidence of new onset diabetes in patients with RAS blockade versus non-RAS blockade. And the summary slide is here showing that almost all of them and the overall showed a significant reduction and having an anti-diabetic effect of these ACE inhibitor or ARBs. And that's why it would be a good choice to use that medication. Lisinopril in that case. Now this second case, 55-year-old gentleman, type 2 diabetes already, dyslipidemia, hypertension, presented to you as a new patient, current medication, sitagliptin, metformin XR, twice daily, glimepiride 6 milligram, amlodipine 5 milligram, already on treatment, and atorvastatin 20 milligram. Physical exam, obese again, blood pressure 124/76, otherwise unremarkable. Laboratory studies, CBC unremarkable, A1C 7.9, estimated GFR is 58, albumin creatinine ratio 85 milligram per gram, and this is equivalent in millimole, and sodium, potassium, all are normal. Again, another question for this case, would you keep the same dose of amlodipine, 5 milligram, with his pressure, adding valsartan, 80 milligram to amlodipine, switching amlodipine to valsartan, or you could use either B or C. So who would say A, keeping amlodipine 5 milligram with the current blood pressure? Not many, other one here, okay. Adding valsartan to amlodipine 5 milligram? Few, okay. Switching amlodipine to valsartan? I see majority, okay. Either B or C? Another few people, okay, good. Well, again, the majority, are doing good here, and the answer is switching amlodipine to valsartan. And the reason is that, going back to the case here, the pressure, I'm happy with it, 124/76, as we will see later in the goals that we'll discuss later on. So I would switch her to valsartan. And this is one example of a study on valsartan itself, where called MARVEL, looking into, and this is good for our nephrologist sitting with us here, he can comment also later on, that amlodipine did not show the same significant difference in the reduction of the albumin excretion in these patients. So we had here more effective valsartan than amlodipine. Not only that, in the same study, the patient normalized their albuminuria in much more significant numbers in people who were taking valsartan. Now, let's move to the guidelines, and hopefully we can have time for discussion at the end. Again, this is in diabetes and non-diabetic. You can see the American College in 2017 used the threshold of 130/80, while JNC 8 panel still using 140/90, and the guidelines recommended for medication in individuals with diabetes lower there, showing that you use the same threshold, less than 130. You have to treat them with somebody who has 130 or above and 80, while JNC using the higher threshold. Now, I'm going to focus more on the American Diabetes Association recommendation with regard of blood pressure, as it's one of the important aspects of managing to reduce complication. You need not to forget the glycemic, but this is not the topic for today. And lipid management has been addressed by my colleague, Dr. Jehan, earlier. And to do anything else with regard to selection of medication that will help you. That's all in addition to lifestyle modification. Now, this is a busy slide, but just I would like to mention that these studies, the ACCORD, the ADVANCE, the HOT, and SPRINT, the most recently is the SPRINT, has been used and evaluated by the American Diabetes Association group before they come with their updating or their guidelines. And again, maybe with time with discussion later on, but basically they ended after reviewing all this data and results to come with their recommendation. And this is 2022, just recently. There is some minor changes on the one before, but this is not changed here, that individuals with diabetes and hypertension who have not a high risk for cardiovascular, what does that mean? 10-year risk ASVD is less than 15, and the target is less than 140 over 90, and it was a strong recommendation, level A. Now, for individuals with hypertension and diabetes with a higher cardiovascular risk, more than 15 or more, the threshold is less than 130 over 80. That's going with the cardiovascular ACC recommendation. But I would tell you that I found that the level B is now, before it was level C. So they have more movement into being more aggressive in treating such people. Now, this slide only to highlight in yellow for you what is considered very high risk. Again, if you don't use the calculation, you can use this one. For diabetes, the very high risk, including diabetes with target organ damage, proteinuria, or in other cases, hypercholesteremia and hypertension. So almost everybody having really very high risk. If you go down to the high risk, you see that's the remainder, almost everybody else without the target organ damage there. And you can see, except some of the people with type 1 diabetes, that would be considered probably in the moderate risk. So most of our patients will be considered either high or very high risk in the category of cardiovascular disease. Now, this is just for the pregnant ladies. The target for pregnancy is 110 to 135 systolic over 85. That is to help reducing the maternal hypertension acceleration with a strong recommendation A and minimizing the fetal growth impairment. Now, we always have to talk about lifestyle intervention to help with weight reduction, and also they recommend the use of DASH, which basically reducing sodium, increasing potassium, and talking about increasing physical activity. I don't think we have time to go into this. This is just mentioning some of the lifestyle modifications that we can use, including the DASH dietary pattern, increasing potassium, reducing sodium, and weight reduction, and so on and so forth. This is the important algorithm that I follow, and probably many of us in the field of endocrinology follow. Now, and this is the updated one again in 2022. You can see, to start with, it depends on your blood pressure. If the blood pressure is more than 140/90, as we said, the ADA follow that one, and less than 160, then you start with one agent in addition to lifestyle management. But if the blood pressure is 160 over 100 or above, then you need to start right away with two agents. Now, one thing new also in this update is that before we were talking about only the presence of albuminuria to start thinking about they have it or they don't. So albuminuria or coronary artery disease, if present, you need to start with ACE or ARB. Before it was not there, it was only albuminuria. So this is something additional added here. And you can see that you can continue using, but if you don't have albuminuria or coronary artery disease, you can see that you can use any of the other classes of drugs. Now, this is going just to continue to say if it's not reaching the goal and you should not be delaying the treatment, you need to continue and escalate your medication, adding, one thing you should not add ACE or ARB together. And also, if the blood pressure is still not controlled, you go and assess the adherence of a patient. But the last point here about considering mineralocorticoid receptor antagonist, I would like to mention that before you jump into that, being endocrinologist, we would like you to refer these cases to see if really they have an adenoma, as we heard from my colleague earlier, Dr. Naji, or it is just a hyperplasia before you start treating. I have seen a case that already started on aldactone, did good, but I didn't know what's the diagnosis yet. So we have to stop, as we know that, to stop medication to evaluate. So before you jump into adding aldactone, at least do the screening for that. You know, you can do the ratio and you can refer to the specialist. Now, this is from the Canadian guidelines in 2020. and regarding diabetes and hypertension should be treated to a goal of systolic of less than 130, grade C, but the diastolic is grade A less than 80. Now, for cardiovascular, kidney, including microalbuminuria, cardiovascular risk factors, in addition to the presence of the hypertension and diabetes, ACE and ARB, both of them are recommendation A level to use, so not much different from the ADA. There is minor difference here for persons who are not on the category of number 2. They are not included in the above. The appropriate choices in alphabetically, but with the level nearby, ACE inhibitor, they put it grade A, ARB put it as grade B, while the CC calcium channel blocker is grade A, and thiazide and non-thiazide-like are also grade A. And another important point in their guidelines is that if you are not achieving the level that you want it to be, they recommend using a calcium channel blocker rather than adding a thiazide, and they put it as grade A. Now, a few points from the European Society of Cardiology, looking again in yellow, that talking about, this is class 1, high-level recommendation from the European as well, to use individualized manner, and blood pressure goal of 130 is the goal. And if you can go lower than 130, it's fine if you can a patient can tolerate that, but not to go to less than 120. And this is important to remember. Now, also recommended that diastolic blood pressure to be less than 80, but not less than 70. So there is some cut point that we need to look into the recommendation and follow. Now, this is again from the same guidelines. Lifestyles is recommended. RAS blocker, ACE or ARB in people with microalbuminuria, proteinuria, LV hypertrophy are strong recommendation there. And a combination of RAS with calcium channel blocker or thiazide. So there's a difference than the Canadian. You can use either. And that's a strong level. So we have some differences here. And this is the answer of the first case, where if you have somebody who is at risk of developing diabetes, you need to consider RAS blockade that preferred than beta blocker and diuretics. I think I'm almost reaching to the end here. I just wanted to add something to our nephrologist here as well. But before that, looking at this nice update information about the guidelines, the others we have touched on, is they recommending in people with diabetes and or high albumin creatinine ratio to use a systolic blood pressure of 120, 129. Now, for the nephrology team here, the KDIGO is looking into a lower number, at least recently. They are talking about less than 120. But I have seen a nice comment here, and maybe our nephrology colleague can comment. And it's mentioned that less than 120 does not apply to the majority, and this is about chronic kidney disease. It does not apply to the majority of our patients with CKD, including those with diabetes that we are talking about today, whom really they are the majority of the people with chronic kidney disease. And actually, they are using SPRINT study, and because of that, they looked into that level. But in SPRINT, there was no people with diabetes. And with that, I would like to leave you with some messages. Hypertension is a major risk factor for atherosclerotic cardiovascular disease and microvascular diabetic complication, and optimal control is needed to prevent and delay the risk of this. In type 1, as I mentioned earlier, it has to be something happening to the kidney. You need to think about it. And in type 2, they are coexisting with each other. And this is the important thing to finalize the thing here, that individualize your patient, looking at all the condition comorbidities, the blood pressure of less than 140 and less than 130 if tolerated, but not less than 120 as we mentioned earlier. And for elderly, to recommend a systolic blood pressure of 130 to 139. And with that, I would like to thank you and to stay safe, although we are ending hopefully the COVID problem soon, but still we like to be staying safe. Thank you very much, and thank you for listening.